Welcome, everyone. We'll wait just a few seconds here to let everyone join, and then we'll begin. All right, looks like we can get started. Welcome to the Healthcare Lounge. The title of today's session is Nothing is as It Seems, How to Counter PBM Corruption with Trevor Daer. So now I will turn it over to Nelson.
Thank you, Kendall. Welcome to the Healthcare Lounge. This is an important topic, and we've got an expert with us who is going to bring a tremendous wealth of knowledge to this topic that I think most of you know that in attacking the overspend in a health plan, the lowest hanging fruit is pharmacy. And it's the lowest hanging fruit because, first of all, there's little noise when you address it. So you can be pretty aggressive without generating that pushback and complaints from employees. But it's also the lowest hanging fruit because of the corruption in the healthcare supply chain, and particularly around the antics and misbehavior of the pharmacy benefit managers, or PBMs. So it is my pleasure to introduce our guest today in the Healthcare Lounge, Trevor Daer, who is the founder and president of Granite Peak Analytics out of the great state of Montana. Trevor has an interesting background coming to the pharmacy world. He started life in employee benefits, running a national third-party administrator, TPA, and spent 4 years as the director of prescription services, helping employers negotiate transparent and cost-effective PBM contracts and solutions. He's also licensed as a broker, so he understands the rest of the employee benefit or healthcare plan space, not just that narrow silo of pharmacy. So it is with my pleasure to welcome Trevor to the Healthcare Lounge. Welcome, brother. How are you?
Thanks, Nelson. Doing great. Appreciate you having me on. It's a nice lounge you got here.
Thank you. Thank you. The cocktail waitress will be around in just a moment to take your order. All right. So let's start with an overview from your perspective of what a benefits advisor or healthcare consultant is facing when he is looking to bring a PBM into a high performance or value-based or transparent health plan, a next gen health plan, whatever you want to call it. What is he dealing with that PBM, and I guess more importantly, that PBM contract? Let's just sort of level set here.
Yeah, I think what's important for advisors to know when they're getting into this space is, number one, there's resources out there to help you. Obviously, that's why our business exists, even though I often say we shouldn't have a business. It shouldn't need to exist, because prescription benefit managers should do what they say they're going to do and actually contain costs and help patients get on the right therapy. So that's number one. Number two, what you're facing is oftentimes 60 to 70 page PBM contracts, which can be pretty daunting, especially with advisors having to know all the other things of a high performing health plan, right? Understanding the stop loss component, the TPA component, the medical management component, right? There's all these components that you're kind of, I think you always do a great job showing that they're all kind of in a normal health plan, but we're calling them out and being transparent about who's doing the services. So we always say, we're an expert in self-funding, but we have a hyper niche in the pharmacy benefits space. So to answer your question a little more in depth, when you're going in and evaluating a PBM contract, it's 60 to 70 pages. It's very confusing, and there's a lot of language that is unwinding the promises that may have been delivered in the first 2 or 3 pages. That's specific to the larger
I've told this
PBMs.
story before. But go ahead.
Yeah, I was just, when we're
Well,
kind of starting
I've
off
told
here.
this story. You've heard me tell this story about the PBM executive I met at the World Healthcare Congress after hours. We were having a cocktail. He had left this large PBM out of New York in a fit of conscience. He said I couldn't sleep anymore, so he had resigned and he'd come over to the light side. But I asked him the question, what does transparency mean to your former employer? And he looked at me, laughed, and said, it means whatever we damn well says it means. I said, no, wait a minute. You've got a contract. What does that contract say about transparency? And he looked at me and he said, Nelson, that contract, you don't have lawyers good enough to understand what our lawyers did with that contract. So this gets to your point that it's not just a long contract, it's a convoluted contract. So what are some of the aspects of that contract? Well, what are some of the behaviors that the carrier or the PBM is going to engage in that you may or may not find evidence of in the contract?
Yeah, there's kind of some primary areas of a PBM contract that, when we're looking at something at a high level to say, is this good or is it not good? One is in the definitions. So out of any contract you ever execute that I've come across, whether it be in healthcare or you're buying widgets for your corporation, the definitions of the contract are probably the most critical in a PBM contract. The reason for that is if the PBM is defining what everything means, everything from what is a rebate, what is considered a brand drug, what is considered a generic drug, what is the starting point in an average wholesale price-based contract? If they set the definition for that, they have full control over all of the pricing. And you would think, well, how do you define a brand and generic differently? Like, go to the pharmacy. If it's a generic, I pay a generic copay. If it's a brand, I pay a brand copay or coinsurance. Yeah, that's if you are working in a normal situation. A lot of times the contract will allow pricing differences and rebucketing of claims to manipulate pricing. Even if the patient is getting a generic copay, they may be taking that generic claim and rebucketing it as a brand to boost their discount from a pricing standpoint. So those are just some high level things where definitions are critical.
What else should they look for in that contract, and what are the implications of those items?
Spread pricing is probably a big one where spread pricing is the practice of basically paying the pharmacy one price, let's say it's $10, and charging the plan sponsor or patient another. So if the pharmacy procured the prescription for $6, they got paid $10, they made a $4 margin. Spread pricing is then turning around and billing the employer and plan sponsor $72 and keeping that $62, which is undisclosed spread margin, if you will. What that model does is it makes it really hard to know and understand how much you're actually paying the PBM to perform the services they're doing. If you look at being a fiduciary of the plan, you need to know, and you're obligated to know, how much you're paying each partner and what are they doing for it and how are they delivering value. And that's what spread pricing makes really challenging. It's not just on a drug. They do it. They try to do that on rebates as well. So they'll get one rebate amount from the manufacturer, but they won't give you all of that money. They'll keep a portion of it.
So I'm a visual learner. So let me offer up an illustration, and will you walk us through this illustration on spread pricing, because it uses specific numbers. And this is an actual example from a Medicaid MCO in Florida.
Yeah, this is a perfect example. In a traditional spread-based model, whether it be Medicaid or a commercial plan, which is what we're advising on, where the pharmacy got paid $7.60, they actually paid, $15 to $16 for the medication. So they lost money. So the pharmacy, who's actually filling and billing the prescription and consulting with the patient, lost money. And the PBM, in this case, CVS Caremark, charged the plan $121.55. So to administer the copay and pay the pharmacy and bill the plan, essentially, in this case, that's what they did. They provided an administrative service.
All right. So you see, this is a great example of how the pharmacy actually lost money, and the employer paid basically an administrative fee that's not revealed, because no service, no drug was provided for that charge, that processing fee that came from the PBM. Trevor, I had someone tell me the other day. So this is firsthand. He was a patient. He went to the pharmacy to fill a drug that was a $500 drug. And after the pharmacy filled it, the pharmacist came to the window, gave it to him, took his money, and then said, "Can you do us a big favor? The next time you have this refilled, would you please take it to another pharmacy? Because it just cost us a couple $100."
Mm-hmm.
So it's those sorts of games where everybody loses except the PBM.
Correct.
All right. So what other examples of games do PBMs play, and how do we prevent that from happening?
Yeah, I think if you focus still on kind of the larger entities, right? We call them the big three. There are three major PBMs that process 80% of the claims in the United States. There, if you actually read the language, right, which is what we find doesn't happen very often, employers just trust that the contract is good, or they have an attorney review it. And like you said, the attorney is going to look at liability, things like that, but they don't understand the pharmacy benefit ecosystem and the problems that exist within it. So when you look at those contracts, a lot of times they'll tell you exactly what they're doing. And, we've got an example of one that we read that said the PBM may adjust the rebate guarantees if there's a decrease in specialty volume. So we don't necessarily want an increase in specialty volume, but we know the pipeline is there. But if for whatever reason the specialty volume goes down, we're going to adjust your rebates. And here's the kicker. Or the participating plan sponsor, truly the payer, right? The one collecting premiums from employees and patients and also funding plans, elects to promote a low net cost drug alternative that results in lower rebates. So if you as the employer say, and this is going to get to one of our next examples, if you as the employer say, hey, this generic is actually lower net cost than this brand that is being, put on the highest tier or lowest tier, if you will, we want all of our patients to move to this lowest net cost drug. The PBM says, nope, we need the rebate. And even though it's not the lowest net cost for you, we need the rebate and we're going to adjust your contract. So it spells it out right in the contract, what they're going to do. And if you understand just a high level about how PBMs work in general, that should be an aha moment. Like, your job is to get the lowest net cost for me. That's what I thought we were engaging you for. And right here in your contract, it says that's not really what we're doing. And then typically in those contracts, it'll say we negotiate rebates on our own behalf for our own business, not for you as the client. So those are the provisions that you're looking for to basically say, well, then what are you actually doing for me that's in my best interest? How are we so misaligned in what's actually happening here?
There was a recent appeals court decision in the First Circuit up in Massachusetts. A labor union health and welfare trust was suing Blue Cross Blue Shield of Massachusetts for failing to act as a fiduciary in several areas where the TPA, they were operating as a TPA, was charging additional amounts of money that benefited the TPA that did not benefited Blue Cross, that came at the expense of the employer. And the Blue Cross and Blue Cross Association also filed a brief in support of Blue Cross Massachusetts, arguing that if we were to be held to a fiduciary standard in these areas, it would destroy our business model. And the court agreed. The court said they're very persuasive in their argument that their business model does not allow them to be a fiduciary. In other words, the way they are making money is at the expense of the employer. It's not saving the employer money, it's making Blue Cross money. That's their business model. And the court effectively said, as an employer, you cannot expect an insurance company acting as an administrator, and they act as administrator, fully insured or self-insured if they're ASO. You cannot expect them to play a fiduciary role. The same holding should be found for PBMs. Wouldn't you agree?
Yeah, that's there's only a couple PBMs out there that will put any type of language about acting in a fiduciary standard on behalf of the client. That basically, now it doesn't make them a fiduciary, and I think that can confuse some people, and they're like, well, it's a fiduciary PBM, they're becoming a fiduciary of our plan. They're not. They're just telling you in writing that we're not going to do anything that benefits us that doesn't also benefit you. We will always put you and your interests at the forefront, and if we're found to not be doing that, then you can sue us. So most PBMs and most administrators are going to explicitly say we are not a fiduciary, we are an administrator. And they're right. I mean, they are administrators, they're not fiduciaries of the plan, but you want to find partners that are going to act in a way that protect your plan assets and your patients, not those that are just going to, run amok because they can and because it's so complicated that nobody will likely catch them.
I know that those of you in the room with us are probably having some questions right now come up. Don't wait until the end with those questions. Go ahead and type them into the Q&A box. You'll see at the bottom of your screen the Q&A button. Click that, type your question in. We'll work to answer those as we go through this session of the Healthcare Lounge, or we'll catch them at the end. But I know that when I have a question, I don't write it down. I often forget it by the end of the session and we get to the Q&A. So please just put your questions in Q&A and we'll get to them. So you make the point that they are not acting as a fiduciary. And look, that's a business decision, right? There's nothing illegal about self-dealing unless you are serving as a fiduciary and you're violating that fiduciary responsibility. So they're just making a business decision to operate in a way that benefits them and doesn't necessarily benefit, and in fact, sometimes might hurt their client. How do they get away with that?
I think that's why we created a business, is to shine a light on these things, to not, to basically say, no, it's not illegal, and you signed the contract, and they basically told you all the things they're going to do that are not in your best interest, but they provided 2 pages of a grid that showed you discounts and rebates, and That's how the evaluation was done, so you signed off. So it's not illegal. I think they misrepresent themselves a lot. I think you can make a case for they start using terms like net cost and transparent and pass through. And we've heard stories of that with people who have left PBMs that are like, we went through our sales deck and determined what was the best phrase we could use to sell this. Even though it didn't really align with what we're actually doing, we started saying lowest net cost. So those are the things that are they're mind-boggling as you get into this stuff. And even though it's not illegal, it's wrong. It's just flat out wrong, in my opinion. And that's what we're always fighting for every day is, how do we make this right? How do we protect? I'm not a pharmacist, right? I can't deliver the medication to the patient, consult them, help them with their disease state. What I can do is climb all the way up the decision tree and help educate others to make more informed decisions and understand where they're getting taken advantage of, why it's hurting their plan and why it's hurting their patients and their local pharmacies in many cases.
So the advisors who are in the healthcare lounge with us today, I hope you understand that these PBMs aren't bad people necessarily. They're following bad incentives. And the problem in healthcare, almost unique in our economy, the problem in healthcare is that the people who should be monitoring the PBM and the TPA and other players in the healthcare plan ecosystem, they're not monitoring. They're not identifying these behaviors and saying, wait a minute, if you're going to do this, we're going to change PBMs. If you don't change your contract, we're leaving and going elsewhere. And all of a sudden, the incentives change because I don't want to lose the business. I'd rather make this much than this much if I have to. I'd rather make this much, but if you're going to force me to sort of be honest about it and deal fairly with you and your employees. Here's the other thing I'll say, Trevor. It may not, when employees can't afford their drugs because the PBM is playing games and forcing them into higher cost drugs, when they're putting really expensive drugs on the formulary, when there are biosimilars available, in other words, equivalent drugs that are a lot less expensive, but they're forcing the employees into these high cost drugs because they want the rebates, and employees can't afford to be compliant with their drugs. That's not a business problem or even a healthcare problem. That's a moral problem. Mm-hmm. It's immoral when you're forcing not just the employer to spend more, but the employees. So the CEOs and CFOs need to be educated by these advisors, and you're the advisor to the advisor when it comes to pharmacy issues. What else do you want them to know? What else do you help them with when they bring you alongside to get them the best arrangement around pharmacy?
I think we talk a lot about the bad actors, right? And why it doesn't work because there's no alignment and incentives. The good news is there are good partners out there. The bad news, again, is it's really hard to identify who they are. So we have what I would consider the new status quo, where they're taking advantage of, hey, we're not the big three. We don't operate that way. They talk the talk, but contractually they don't walk the walk. They're playing a lot of the same games, just under a different name. In many cases, they've contracted with the big three to do all the services they're doing. So it's just, and it's no different in PBM consultant world. There's a lot of PBM consultants or technologies out there that sound really great. Really, what we call that is you're taking advantage of the broken system for your own gain, and you're not delivering all the value back to the client. You're being paid by a PBM to place business with them. Well, how are you supposed to negotiate with them then if they're paying you more than the employer plan sponsor is? How are you supposed to negotiate with, a PBM that you are always placing business with? So it takes away the independence, the unbiased approach. And there's a lot of that goes on, and it's really frustrating. And the only way we can kind of shine a light on it is to show people and educate people. Like, there's a lot of people out there offering to help you, but are they just getting you and your clients to less bad, or are they getting you to fully optimized?
Part, and maybe not part, maybe all of the problem, besides misaligned incentives, is there is so much money involved here. And some of the advisors, and when I say advisors, I'm really talking about the big brokerage firms, because the guy on the street, the producer, the sales guy for Aon or Willis or Brown and Brown or Gallagher, has no clue what's happening at the levels that I'm about to talk about. But I know, and I think we all know, that the bigger brokers are getting paid a per script fee by the PBM. Well, you think about how many employees take how many drugs every month at $1, $1.25, $1.50. And depending on your size, you can get that kind of a per script fee from the PBM as a price of them doing business with you. But they're also then sharing in the rebates. PBMs share in the PBM's rebates, which I'm quick to remind the TPA, they're not the PBM's rebates that you're sharing with the PBM. So there's so much money out there that it does corrupt. I mean, it's no longer a vendor; it's a revenue stream. It's not a necessary component of the health plan. It's a profit center for these companies. One TPA told me, I said, "Can our advisors bring their own PBM with your TPA?" And he hemmed and he hawed. Oh gosh, gee, oh gosh. Well, finally he said, "I guess so, but there'll have to be an adjustment." I said, "An adjustment to the PEPM?" Well, yes, because we share in the PBM's rebates. It's like, well, hand in the cookie jar. Everybody's got their hand in the cookie jar. So could you give us three areas or three items that advisors should know to look for? They may need to call to get the details, but when they're looking at a contract for an employer, are there 2 or 3 items that they can scan for and point out to the employer, here are some red flags, at least red flags in your PBM contract that we should talk about?
Yeah, I would say number one, this one is mind-boggling to me, but when you're hiring a PBM, if they own 15,000 retail pharmacies that they're supposed to be negotiating with, that's the biggest conflict of interest there is, right? Not only 15,000 retail, but specialty pharmacies and mail order pharmacies. So that's the definition of the fox guarding the hen house. I'm hiring you as the PBM, and you're saying, just trust us. We're going to negotiate really well with our own subsidiary. How does that make any logical sense at all? That's number one. If you ever come across that PBM in that contract, it doesn't even matter what the contract says. It's just like, hold on, this doesn't make sense at all. We're hiring you to negotiate with yourself. I think the deck is stacked against us. And just trust us and don't reconcile your contract, because we got it. We'll reconcile it for you. So that's number one. Number two is look at the grid that everybody pays attention to is the rates, the discount rates, the dispensing fees, and the rebates. Look at that section and identify whether that says guaranteed or expected or average, because there's a fair amount of contracts out there. And this is, I'm speaking in general terms, right? You're not always going to get guarantees regardless of what PBM you have on a 50 life group, right? But if you're an employer of size, a larger size, I would say, and those are the employers you're working with, we still see it all the times where there are thousands of employee lives and they're not actually guaranteed anything. They're just getting, this is what we expect to hit. So then if you go back and ask them, or hire us to go in and do a claim level monitoring that says, here's how you actually performed, they have no risk. They have no accountability. We come back and say, well, you didn't meet expectations. They say, well, we told you it was expected. It was average. That's another place where PBMs will play games. And I would say the third place that I would look would go back to the definitions. It's usually the first couple pages of a contract. If most contracts are based on average wholesale price, that's just it's not an ideal metric and it's not an ideal price point, but most contracts are based on average wholesale price. And look at what the definition of average wholesale price is. If it's not tied to an independent entity such as Metaspan, and it allows them full autonomy to assert their own proprietary average wholesale price, you're basically allowing them, just like you would a hospital in a percentage off build, to create the build charge that they want. Now, how can they not hit a discount when they're creating the starting price? It's like they're going to hit it, but was that the lowest net cost prescription? Did they get you the lowest net cost? Probably not. So those would be the three areas that I would really focus in on. We've got a nice 2-pager that kind of identifies what you should look for. I always think it's interesting that a lot of people want to hold that close to the vest and not share it. They're like, oh, that's our secret sauce. I don't think anything should be secret, really. If I can help an advisor by providing them 2 pieces of paper for free and educate the ecosystem, awesome. I'm going to do it. I'm going to give you all the knowledge I can. Now, when it gets more in depth and you need more help, we'll be here for you. But I think one of the questions was, can we have some ideas of the definitions? Yeah, we have a document that we can distribute out along with what we feel is a really nice leave behind for employers, which is kind of pharmacy contracts exposed. It's 1 page that says, here's what you should be asking about your pharmacy program. And it's a lot of the stuff we've talked about here.
All right, we're going to I'm going to have your email address put in the chat, but we'll also show it at the end on a slide that has that in your website, both. So yes, you can. And what could they put? Just 2-pager in the subject line?
Yeah,
and email you. Would that work?
Yep.
Is that fair?
Mm-hmm.
Okay. There was a question. Do we need a copy of the slides? Actually, there are only 2 slides. But they're not available, but the video is available, so you'll be able to revisit the slides on the video, on the replay. Let's see. So we just talked about common examples of contract terms that can be shared. So we're talking about negotiating with your owned pharmacies is one thing to look for. Another is whether the rates are guaranteed or expected or average. And a third would be the definition of average wholesale price. Is that right?
Yep. Yeah.
Okay.
Absolutely.
All right. So we've answered that and we've answered that. All right. Another question. Can we walk the examples of spread pricing? We can indeed. 1 second.
While you're doing that, Nelson, we have a question that I think would be good as you're pulling that up is, where can we find the PBM contract? And it says, I have serious difficulties getting the PBM to do anything. Appears to be coming from an employer that may be on, or if there's a question from an employer, if you're self-insured, you should be able to get the PBM contract. If you're fully insured, you're not going to get the PBM contract. That's all baked in. But if you're self-insured, you are on the risk for what that PBM contract says. So be happy to help you obtain that. Usually it depends on who holds it. A lot of the times the TPA will hold it. But you should have something executed that either joins you to that contract and says you have access to read it, So those are, yeah, the PBMs, I say, you don't get what you ask for, you get what you negotiate with them. And that sometimes comes with a lot of battling with, I can't even get my hands on it. They don't even want to provide it to me. It's behind like 7 firewalls. Well, that's where you pull your fiduciary card and say, I'm a plan fiduciary of this plan, and I need to know what these rates are that we're paying prescription claims for. So we can absolutely help with that.
You bring up a great point there. In next gen benefits, we talk about the 3 main areas that a broker has to evolve in order to be an effective gen advisor. And those 3 areas are tool set. You got to have a new set of documents, new set of vendor partners, a new set of strategies. Tool set. Skill set. You have to have the skills to use those tools, those documents, those know when to put the right vendor partner into a plan. You also tool set or skill set is also about having the language to have a conversation, a strategic financial conversation with a CEO or CFO in the C-suite. And then the messaging to deliver to that CEO or CFO to help them understand, I've got to change, don't I? Yes, you do. The third, tool set, skill set, mindset. And the mindset is at times the hardest to change, because if you've been a broker for 10, 15, 20 years, you've got neural pathways that have been formed in your brain about how you operate. And if you've been mostly or exclusively fully insured with your clients, you're not used to asking for anything. You're certainly not used to demanding anything, because the answer is no. Go pound sand. No, go pound sand. Go play golf. Or the carriers don't want you around. They don't want you involved. They want you go away. Here's some tickets. Go to the. We're going to send you down to the Masters. You've been good for us this year. Here's some tickets to the Masters. Go play golf. Go on a cruise with us. Don't ask about the health plan. But when you're self-insured, not only does the employer have a fiduciary responsibility, but as the advisor, you've got a responsibility to make sure that the information that fiduciary needs, the CEO, CFO, is available to them. And that requires being forceful with an entity that doesn't want to give you diddly squat, whether that's the PBM, the TPA, especially if you're working, good Lord, if you're working with a BUCA, ASO, administrative only services program, they're going to treat you just like it's a fully insured plan. That's how they're wired. So being aggressive and forceful, it's not what you get, it's what you ask for and negotiate to get, or they're not going to hand you anything. And Trevor, how many times have you gotten incomplete data when you've requested data on the pharmacy spend? It's like, yeah, I think we have some fields missing here.
Once a week.
Yeah. And I've seen, and it's not necessarily on the pharmacy side, but I've seen some documents where they're actually words marked out, sentences marked out. You think, would you get this from the CIA? And they've marked out all the top secret stuff that they can withhold. I mean, it's absolutely crazy. It's whose data is this? It's the employer's data. It's not the insurance company's data. It's not the PBM's data. Let me bring up this spread pricing example and walk through that again, if you would, Trevor.
Yeah. So real quick, we'll go through the acquisition cost of the drug. What the pharmacy paid for it was $17.56. What the PBM reimbursed the pharmacy for, not just counting pills and putting it in a bottle, but doing safety checks, doing, clinical counseling. They paid them $7.60. So the pharmacy lost about $10. And then they billed the payer, in this case, it was Florida Medicaid, $121.55. So that is the example of spread pricing. And you can use the same example with rebates. It's just, it becomes the drug manufacturer pays let's say $400 of a rebate, and you pass back to your employer $300 or the payer, and you keep $100. So hopefully that there's a lot going on the Hill right now about spread pricing, and it's amazing. It's amazing some of the arguments that are made to keep it. One I heard was we have, from one of the larger entities, major health plans, right? Spread pricing provides predictability, and why would we want to get rid of that? And the all the legislators in there just glopped onto it. Well, yeah, don't, as a business, you want to have prediction, you want to be able to predict. And my response was, the only thing you can predict is that you don't know how much money they're making, and your costs will continue to go up. That's the only predicting you have. That's it. I mean, I've seen spread models all day, every day, and that's what happens. The costs go up, and you can't hold the PBM accountable because you have no idea what they make. Now, the CAA, which is a completely separate webinar, Consolidated Appropriations Act, gives you the tools and resources to actually see how much money they're making. It's up to you on whether you take advantage of that.
And it's probably worth mentioning because you certainly know, but some of our attendees may not. The big three are CVS Caremark, which is, well, the CVS Caremark, Express Scripts, and Optum. Optum is owned by United Healthcare. Express Scripts is owned by Cigna, and Aetna is owned by CVS Caremark. So two of the big three are owned by carriers, by the Bucas, and the third owns a Buca. All right. So it's by the way, tell me we're not in bizarro world when a PBM can buy an insurance company. I get it the other way around, but when there is so much money, and Optum is the PBM that UHC owns, is United Healthcare's most profitable division. I dare say that Express Scripts is probably Cigna's most profitable division as well, because the drugs don't apply, the drug profits don't apply to the medical loss ratio, which is kind of cool for them.
Right.
They get to keep all of that out of the MLR decisions. All right. So, and by the way, the advisor who was asking about the getting the contract says this was Cigna, PBS Express Scripts, and with an all-state plan, and the PBM refused to give me, the advisor, and the employer utilization report. So, what do you do in a case like that? What do you advise?
Yeah, I think maybe it's All Savers, Cigna level funded. I'm not sure, but in a level funded plan, there's definitely some little wrinkles that they have in there where they're keeping some of the money, and they also will restrict the amount of data you can get. So happy to help on that and look into it in more detail. But sometimes they've basically signed on to that level of plan, and they treat it, to your point, a lot like fully insured. That depending on size, they won't release reporting. And sometimes there's nothing you can do about it. Sometimes there is. A lot of times we look at, the ecosystem within NextGen with some of the great kind of level funded solutions that could replace a Cigna type bundle plan. And there's a lot of good ones out there.
Every once in a while, we get an observation or a comment from an attendee here in the Healthcare Lounge that's worth reading word for word. And I'm going to do a shout out here to Frank Conklin and just read his comment. The problem is both the siloed health insurance operating system and the PBM operating system, which are misaligned with employers and patients, regardless of whether or not they should or should not be designated fiduciaries. Employers have acquiesced to the status quo broker, TPA, insurance ecosystem for decades, and employers need to force change. That's the only place the change is going to come from. That's Frank, so well said. I really appreciate that. The the fact is, in next gen benefits and any plan that is disintermediating, getting rid of the middleman, disintermediating the insurance company, putting in a third party TPA, an independent PBM that's not one of the big three, et cetera. The reason we're able to control costs is it's singular. We're leveraging the employer's checkbook. That's what gives you the power to say, no, we're not going to do that. No, we're not going to pay that. No, we're not going to accept those sorts of behaviors. And so that comes down to the decision isn't the advisor. The advisor can't say, Mr. Employer, I'm going to fix this for you. Not unless the employer says you're hired. And yes, use my checkbook to make change. So it really does come down to the employer, but the employer doesn't know they can do anything. I mean, it's astounding to me how helpless these otherwise powerful CEOs and CFOs are when it comes to healthcare. And they just throw their hands up and go, I don't know, nothing I can do about it. And they've been trained. With healthcare's big lie. You can't control the cost of healthcare. Well, we know you can. It is a lie, but there's education required. And that's why I love what you do at Granite Peak, because pharmacy is probably the most opaque and confusing. And it is complex. I don't think it's really complicated, but it is complex. In fact, let me share another slide just to show you how complex it is and just how much overspend there is in pharmacy. So I want to give a shout out to Vivio, who posted this maybe a week or two ago on LinkedIn. And it's a great illustration of where most employers and employees are overspending on the drug when in fact they could spend a lot less. And you can see it's the different players in this, and everybody's taking a piece, everybody's taking a slice, everybody's got their hand out. And it's the employee and the employer that's having to cross that palm with silver in order to get that drug at an outrageously marked up price. So can you walk us through this?
Yeah, this again goes, it's funny. We always say, just do math sometimes, right? And the math will set you free or at least help educate you on what's going on. So this is an example of Humira, the biggest blockbuster drug of all time, finally went off patent, or finally the litigation was settled about their patent. And when you look at, this is why we always say, in a traditional buying ecosystem, buying, selling, supply, demand, value, right? This would be a no-brainer, common sense. This is how it should work. We don't live in that ecosystem in the US pharmaceutical supply chain. We just don't. It's stacked. It's, and monopolies and oligopolies are on both sides, the wholesaler side and the PBM side. So when you look at this drug, and this is, I think, an annual example of Humira, by the time you take out the manufacturer's profit, which of course a manufacturer needs to make money, you pay the GPO, which is negotiating rebates on behalf of a PBM often, the wholesaler, the PBM, all those parties, you end up at $34,000. And it's amazing to me that that's just how it works. So then you look at Yusimry, which is an approved biosimilar, and you can get the same active ingredient, same mechanism for $8,400 now. Now, what's no different than it has been in the past here, right, is there's a lower cost alternative to Humira. The question is, will the PBMs cover it? Will they put Yusimry as a tier 1 or a tier 2 and move Humira to tier 3? 95% of them will not. Why? There's no rebate line. There's no rebate revenue. And that's where they're making most of their money, or not most, but a fair amount of their money. So they are not incentivized, they're not aligned to cover the lowest net cost medicine. A lot will say, well, we'll add it as a preferred formulary alternative, but they're not going to drive anything that way, because not only are they making a ton of money off of Humira rebates, but AbbVie's a major manufacturer that manufactures a lot of other medicine. And AbbVie's going to say, if you put that drug on there and you prefer it over ours, we're getting rid of all your rebates, or we're substantially reducing them. There's a lot of math going on in the back end with PBMs going, well, if they do that, even if we're saving our clients money, that's going to be a huge financial hit to us. And that just shows you that it does defy common sense in a traditional buy, sell, supply, demand ecosystem. It makes perfect sense in the broken system we work in today.
Yeah, just thinking about this, I wonder, is rebate, I usually did pretty well in spelling in school. Is rebate spelled BRIBE?
Mm-hmm.
I think so. It may be an ethical bribe, but it's a bribe nonetheless. In fact, my understanding is the reason the rebates have gone so high is oftentimes it's an arms race between the manufacturers to get their drug in a preferred position. People don't know, in the grocery stores, grocery store chains are paid by food manufacturers for placement. They want to be on eye level shelves, not down at the bottom. They want to be on end caps at the end of an aisle, and they pay for that privilege. The pharmaceutical companies are doing the same thing. Again, it's not illegal, but nobody is calling BS on it. Nobody's saying, well, yeah, see, I understand why the drug company wants to bribe you to prefer Humira over Yusimry, but we are going to have Yusimry put at the top of the list because that's what's best for us. We're the client. Or we'll change PBMs. That's not happening. I wanted to, there was a question. Generally, we're at the mercy of who the TPA decides to use as their PBM. So not only do we need to thoroughly read the contract with the TPA, but request and read the PBM contract and then adds and hope we really know what the contract says. But this is why we at Next Gen Benefits, we always argue for what we call an unbundled TPA. In fact, a Next Gen TPA is one that is unbundled. They may have their preferred PBM, but they don't require you to use them. That's an option that you and your employer get to make, a choice that you get to make. And if you don't get that option, change TPAs, because the PBM is costing you and your client's plan a tremendous amount of money. I'll give you a quick example of the difference it makes. Dan LeBrod with Ovation Health in Dallas has a client. The company is called Corby. It's about 400 employees in the Dallas area, and they are a staffing and business process outsourcing company for technology. They do a lot of work with Google and other big tech companies. After Dan addressed the PBM and the specialty meds, Corby was spending 25% of what they had been spending on pharmacy. Everybody was getting their drugs, and those employees with high cost maintenance or specialty drugs were paying zero out of pocket. Might have been paying $400 a month before. Now they're paying zero. In other words, that's a 75% reduction. And I don't know that is particularly an outlier. It's the most I've ever seen, but that's how much overspend there is in pharmacy. So when Trevor says he can help because it starts with a contract and it goes through enforcing the contract throughout the year, keeping your eye on the ball, not setting and forgetting. Okay, we got a good contract with PBM. Now we'll just let them do their thing. I wouldn't advise that. Would you? Trevor?
No, I mean, set it and forget it in this market is probably the most dangerous thing you can do with your prescription plan. We say, like we said, there's good actors out there that can help deliver. Sometimes you don't have a choice. And to that question we had about sometimes the TPA dictates it. I get it. But there's still levers that can be pulled within the ecosystem as you walk that client to a better solution going forward. So it may not always be that we got to rip it out and throw something else in. Might be, all right, let's pull the levers that we can and negotiate with what we have, and then continue to monitor it, and hold that PBM accountable. Don't trust and verify. Sometimes, you know, with team members, right, you want to trust them, but also verify and validate that they're doing what they need to do. In our world, is don't trust a thing. Don't trust anything a PBM says. Remain skeptical, and then verify and validate their performance. And when they perform, we applaud the heck out of them. We, you know, the good PBMs embrace us optimizing, holding them accountable, helping them get better, because we all start winning. So I would just say, absolutely, to your point, don't get caught up in discounts and rebates. They're two components of a very complex math equation. It's not what you save, it's what you spend on a per member per month basis. And there's too much that people continue to buy on that discount and rebate basis that shows them savings. Go back and look at what your broker produced as a estimated savings last time they showed you the 3 pre-negotiated deals that they have, and see if it ever came to fruition. I talked to a 30,000 life company a while back that was in one of those coalitions, and I'm like, I guarantee they presented you 3 options that they RFP'd, and they projected millions in savings. Did you go back and validate whether those ever occurred? No, that's a good idea. Monitor, measure, do it again. The marketplace is too insane right now and too volatile, especially with specialty drugs, high cost brands, diabetes and weight loss. You can't afford to just set it and forget it. And that's why we exist. You don't have to know all of this stuff. You have to know who to ask and who can support you. And that's part of the tool set, the skill set, and then we'll help you with the mindset. But you don't have to know everything to go educate employers on why they're getting ripped off.
There's a question about the PBMs that you recommend to your clients. I'm going to hold back on that because that's a little bit of your secret sauce, knowing who to work with and having helped help develop their contract. There is a great question here. Is there such a thing as developing your own customized formulary for a plan, either by ourselves or with a progressive PBM? And is that something you help with?
It's a great question from Barry, who I know. Hi, Barry. It is because the rebates have gotten so insane. I feel, and this is just my opinion, it's very hard to build your own custom formulary that's going to deliver true net cost. So even when USIMRI came out, we saw a lot in the market. All of my patients on Humira are going to be moved to USIMRI and my clients are going to save. Well, not if the PBM contract that you have in place says that all your rebates go away and the PBM gets to keep them. Then you haven't saved anything. So in common sense, if the market worked how it should, absolutely, you go from a $7,000 drug to an $800 drug, you should save. But hold on, what does your PBM contract say? And what do you, and typically it's very one-sided and they're going to do things. So that's the long answer of custom built formularies are available. You typically have to pay extra to the PBM to administer them. And it requires a lot of clinical expertise in managing and monitoring. So our goal typically is to say, find a PBM partner that you really believe manages a net cost formulary, and then keep them accountable to managing it that way, opposed to trying to build your own, because they're still going to have some flexibility.
Let's see, quick, before we go here, there was a great question Trevor, when are you going to start an innovative PBM that delivers the lowest net cost? Or would you be prevented by the pharmaceutical and PBM industries? So
That's how I started. I went down the rabbit hole of creating an innovative PBM and one that did the right thing. And what I found was I would be outsourcing everything to start, and there were good middle market solutions already there. So my job quickly became, why would I create another PBM to compete with them? Why don't I help guide and advise people to work with them and then help optimize what they do and hold them accountable? That's the direction we headed. And I will say it's been a whirlwind, but I'm glad I didn't start a PBM.
It's a lot of compliance too that would drive me nuts. All right. This has been fantastic. And Trevor, thank you so much. You are a font of knowledge. And I know we've actually just barely scraped at the top of the iceberg, and below the water, there's so much more knowledge, but also that expertise that you bring to bear. I should mention that Next Gen Benefits has an A team of subject matter experts, from medical director to compliance, ERISA attorney, global benefits specialist. And we are delighted and excited to have Trevor Daer as our director of pharmacy at Next Gen Benefits. So it's great to have you on board for that. So let me, as I promised, let me go to this slide here and let everyone copy down your contact information. Right here, it's td@granitepeakrx.com. The Trevor's initials, TD. And granitepeakrx.com is Trevor's website if you'd like to go and check out the service they offer and the work that they can do for you and your clients. Trevor, as always, it's great to see you get back to enjoying the kids and chasing them around. And we'll look forward to seeing you. Actually, you'll be at our Mastermind Summit in 2 weeks here in Nashville. So looking forward to seeing you there. In the meantime, everyone take care, go out and make a difference, and help your clients take control of their healthcare. And we'll see you next month in the Healthcare Lounge.
Thanks, everybody.